recording out. Share my screen. And do this lecture completely virtual this evening with a beginning of review. We did start this chapter last week, so I'm going to do a brief review of the radiographic imaging that we're going to do tonight, and we'll go through, and then we'll also hopefully complete the material. So again, we're going to talk about the full mouth survey of x-rays. Anytime we take x-rays, just to recall, we want to make sure that we only take them when necessary, and we only take what we need. For comprehensive dental exams, they're always going to believe with some type of full mouth series of x-rays or radiographs, or a mixture of a panoramic x-ray and some bite wings in order to complete an actual comprehensive dental exam. Why? Because if we're seeing why we do comprehensive exams, or the frequency, it would be for new patients where we've never seen them before. So we definitely need x-rays of some type to see anything that's going on without seeing it visually in a person's mouth. That's why we do radiographs to this extent. Or we have an existing patient that we may not have seen in over 3 years. Again, it's going to be per provider preference of what we look at, or when the frequency to which we take x-rays. A full mouth set of x-rays, or FMX or FMS is abbreviation. They contain periapical and bite wing images, which we'll later see what they are. But by definition, a periapical image is going to show the entire tooth structure, which includes the crown, the incisal or occlusal surface, which is the biting surface, and 2 to 3 millimeters beyond the root to show bone, root formation, and eruption. Again, a tooth for periapical should be the identical size as it is in the mouth anatomically to the exact image it looks like. A bite wing image is going to show the upper and lower teeth in occlusion, so biting down. This image is useful for detecting decay in the interproximal areas, early periodontal disease, recurrent decay under any restorations, and fit of metallic fillings and crowns. An adult full mouth set of x-rays is going to range between 18 to 20 images. If we're talking about 18 images, it'll be 14 periapicals and 4 bite wings. Again, the number will depend on doctor preference. And if we do see an FMX that's 19 or 20 images, typically it's going to use a different size film. Our standard 18 image will be a size 2 film or sensor. And if we're adding anterior number, meaning we're using a size 1 film, because we want to see more anterior teeth, we may get to 19 to 20 images, meaning instead of taking 3 anterior, we may take 4 maxillary and 4 mandibular, or 4 maxillary and 3 mandibular, and that's how we get that range between 18 and 20 images. This is a standard full mouth set of x-rays. It's the 18 film or 18 set, whether it's digital or film based. These are 18 radiographs. We're using a size 2 film, and this is for an adult dentition. I want you to notice this picture. It's actually the top, right-hand corner. If you're looking at it, it says number 2 and 3, 4 and 5, 6 and 7, 8 and 9. Those are the teeth that should be in that image. And you need to make a note of each tooth, or each 2 teeth, or for bite wings, it's going to be obviously multiple teeth that need to be in that image to make that image correct. Okay, so that the positioning or placement of the film or sensor is accurate to the tooth number that you need. So by all stretch, this is a good gauge or a visual showing that a upper right molar shot is going to have absolutely tooth number 2 and 3 in it, as well as you can see the wisdom teeth here, which is number 1 in this case. So you can say 1, 2, 3. Notice how there's going to be some, you want to take a look at where the teeth are coming together, the contacts, and notice how each of these contact areas between each tooth, these are good quality pictures because you can see through the interproximal space, and that makes it a good quality picture. So we're going to talk about some intraoral imaging techniques. So right now, this whole chapter is based on any image that we're taking inside the mouth. Again, we can use digital, sensor, PSP plates, or conventional film. I'm going to call, from moving forward, I'm going to say image receptor to represent any one of those three, okay? No matter what it is, the basic techniques are going to be the same whether we're using digital, PCP plates, or conventional film. There's two basic techniques that we talked about the other night. It's paralleling technique and bisecting technique. Paralleling is always going to be recommended because it gives the most accurate view with the least amount of radiation exposure, meaning the least amount of mistakes or redos that we have to take for a patient exposing them with unnecessary radiation for our errors. Bisecting is used when a patient has a small mouth, a shallow palate, or tori, as well as children. Paralleling technique, as a reminder, it's also called extension cone paralleling, or XCP, right angle technique, or long cone. When we're discussing paralleling technique, remember the terminology that we're going to use: parallel, intersecting, perpendicular, right angle, long axis of the tooth, and central ray. Again, parallel means equal distance from one aspect of the tooth to where the film is. Intersecting is going to be where the central ray goes through that long axis of the tooth. Perpendicular is going to be the angle or the right angle, which is 90 degrees from the long axis of the tooth and the central ray. Long axis of the tooth is the imaginary line that cuts right through the center of the tooth. And the central ray is the primary beam that's coming out of the positioning indicating device, or PID. This picture examines that more closely. You see the long axis of the tooth that's generated by this dotted line. That's the imaginary line. Our film is our film is parallel to the long axis of the tooth. Therefore, the central ray is intersecting at the long axis and then becoming perpendicular or right angle as it's hitting the film. This is a shot of a canine or an anterior tooth, and this is a shot of what a molar shot would be, where you have your long axis of the tooth is the imaginary line. Your film is going to be parallel to that, and the radiation beam or central ray is going to intersect and become perpendicular at a 90-degree angle. Paralleling has 5 basic rules. Again, it's the most recommended. The 5 basic rules are going to be image receptor placement, meaning we have to cover the correct teeth. Exactly what that full mouth set of x-rays showed us earlier, where let's say we wanted a molar shot. We know that that molar shot has to include teeth number 1, 2, and 3, and it'll be centered over 2, so that we know we can get tooth 1 and tooth 3 in the same picture. So covers correct teeth for placement. Image receptor position. This is everything to do with positioning the central ray. So we're positioning or paralleling to long axis of the tooth. We're placing the film or sensor away from teeth toward the middle of the mouth. So image receptor position is exactly that. It's for paralleling, our sensor, our film or PCP plate is going to be more toward the middle of the mouth, creating that parallel line between the film and the long axis of the tooth. So that would be proper positioning of the image receptor. Vertical angulation has everything to do with the PID, the positioning indicating device, which therefore is going to dictate where the central ray is going to be focused. So vertical angulation, which is up and down, the central ray must be directed perpendicular at that 90-degree angle to the image receptor and long axis of the tooth. The horizontal angulation, again, PID or central ray direction. Central ray must be directed through the contact areas between the teeth. So that's going to be right and left. You want to make sure, again, it's directed directly through the contact areas. And again, because we can't see the X-ray admission, we're going to make sure that we have a good idea visually where those imaginary lines are going through. Central ray must be centered on the image receptor. Failure of this can result in a partial image called cone cutting, meaning we're going to cut out some picture here. This is an example of a cone cut. These are more examples of a cone cut where our central ray is completely off center or off the 90-degree angle. Just more pictures here. So again, just to review how we prepare a patient, we want to make sure all of our infection control protocols are met prior to. That means cleaning the room, disinfecting the room, and pre-setting up all area, all instruments, and anything that we may need prior to seating the patient. Once we get the patient, we bring them in. We put their lead apron on before we take any x-rays. We do not wear gloves. No gloves are used when draping the patient prior to radiograph. So we do not need to have gloves on for the lead apron. Once we put that on, we're going to, you can use alcohol or wash our hands, then you glove up, then you can get your equipment or supplies ready. Therefore, no cross-contamination can occur. Now, exposure sequence, I'm going to go through the recommended or the standardized sequence. However, a lot of offices or providers or practice management software will have a default that starts from the molars. It can start from anterior. It can start with bite wings, and it's really dealer's choice there, okay? But we're going to start primarily with the posterior exposures and work our way up. So we plan our exposure sequence so no images are missed or repeated. That's the only reason why we want to plan ahead of the sequence so we don't miss anything. When we're using digital radiographs, obviously it's very difficult to miss or repeat an image because the fact is the computer programming already has a sequence drawn out for you, and we follow the leader on that. However, if we're using conventional film, you should prepare by laying out your film in sequence not to miss and have that sequence outside the room so you're not exposing the film prior to actually exposing it in the mouth. We are going to start, it is recommended to start with the anterior teeth using either a 1 or 2 size film. We can use office or doctor preference. The reason why we would predominant or recommend anterior start is so that we don't trigger a gag. Once you trigger a gag, it's very hard to reverse. So basically we try to avoid that and start with the anterior teeth first. We want to start right to left maxillary, and then we drop down left to right to the mandibular. So it's like a C that we're going. We want to avoid wasted movements. And that means that when we're using the XCP that we use, our color-coded, our yellows, our reds, our blue instruments that we've seen with the bar, the ring, and the bite block, then we don't have to waste movements. Again, we don't want to make patients uncomfortable, and time is of the essence. For posterior exposures, we want to always begin with the premolars, because they're easier for patient to handle. They're less likely to cause a gag reflex. We're going to do 4 maxillary images and 4 mandibular posterior images. We start with the upper right quadrant. And then we drop to the lower left quadrant, so we do not have to change any of our XCP position. But once we go to the maxillary left quadrant, we have to change the position there because the bite block won't fit in their mouth. We have to literally reverse it because we're on the mirror image of the area. Once the maxillary left quadrant, your premolar and molar shot is complete, then we're going to go down to the mandibular right quadrant and start with the premolar molar position. Now let's talk about bisecting technique or review the bisecting technique. So bisecting technique, as you can see here, we're still using the central beam. We still have to have the long axis of the tooth, that imaginary line. But notice where the film is placed, or the sensor. It's placed butt up against the tooth structure, or as close to it as possible. And there we see the line C, which is bisecting angle. That's going to be our imaginary line that bisects the long axis of the tooth, so the middle of the tooth, and the film. Here, you want the 90-degree angle where it's going to intersect or create this perpendicular line with the central beam to occur at the bisecting angle. That's where the right angle will take its place. That's where we want to be perpendicular, with the bisecting angle. So a lot of bisecting technique, and why it's not widely used, is because we're using a lot of imaginary lines here. The long axis of the tooth, bisecting angle. All of that is completely imaginary, and we have to visually put that in the space there. So bisecting technique is also called bisecting the angle, bisection of the angle, or short cone technique. It's used in special circumstances, such as very small mouths, children, somebody with a flat palate, tori, and possibly during endo procedures. There's a spelling incorrect. Sorry about that. Key points. Film or sensor is moved directly against the teeth to be exposed, creating the film or sensor to be at an angle. The central ray is directed perpendicular to that bisecting line, as we saw in that picture prior to. So for bisecting the angle instruments, we can use just regular plain plastic bite blocks, styrofoam bite blocks, if they have plastic aiming rings or metal indicator arms. But typically for bisecting, we do not have rings or arms. So that's where a lot of the guesswork comes in. The stave bite blocks are a styrofoam looking or plastic looking bite block, and the easy grip holders. These are the stave bite blocks. This is what it would look like if you were using a bite block. There's no ring, there's no arm or anything, but it is giving us B is the long axis of the tooth. D is going to be the bisecting, and you can see what the yellow is showing, the 90-degree perpendicular line at that bisecting angle. And C is going to be your image receptor. Different types of holders. So here's an example. So for bisecting angle technique, what you have here, these are the easy grip, and you can also see a forceps being used because we can't fit anything else in their mouth. And then paralleling technique, which you're more familiar with, are these color-coded, your bite wing, your anterior, your posterior, and your endo XCP. And as promised, here's your snap array or easy grip. Here's where you would put the image receptor. It's made for both film or sensors. You're going to have a different looking one for a sensor. This is a film-based. And here again, no ring, no arms, no metal arms to indicate where your PID. This is for absolutely bisecting the angle. Now let's talk about angulation of the PID. So bisecting technique, the PID is critical. Angulation is the term used to describe the alignment of that central ray beam in the horizontal and vertical planes. So imagine the central ray beam, wherever we focus our PID or tube head, that's the central ray. Okay, so you're imagining the direct center of that PID. If we're using it So for horizontal angulation, if the central ray is to right or to left, we're going to have an incorrect result, meaning we're going to get overlap of the contact areas because we did not get that central ray between the contacts. It was to right or to left and caused an overlap at some point there. Angulation continued. So vertical angulation, this is when our central ray or PID is up or down vertically. It is measured in degrees according to the markings on outside the tube head itself, and it differs depending on techniques used. It's usually through a 0 to 60 or a 0 to 90 degrees, 0 being absolutely flat. If we're looking at a positive angle of where the PID is, it'll be positive. Or if it's pointing downward, it's going to be considered a negative PID number, -10, -20. So paralleling technique, the central ray is perpendicular to the image receptor, which we talked about, and the long axis of the tooth. But in bisecting imagery, the central ray is directed perpendicular again to the bisector line. So for the bite wing technique, which is slightly different, it's predetermined. The central ray is going to be at like a 10 positive to the occlusal plane. So that means it's going to be slightly up, just slightly upwards, so that we can grab the entire image of the bite wings. Now, for correct vertical angulation, the image is the same length of the tooth, ideally. If there's any incorrection where our PID or tube head is pointed too high or too low, we're going to get either elongation of the tooth, which is going to look really long, or foreshortening, which will shrink the tooth down to like a nub. So for elongation, that means we have insufficient angulation, meaning not enough vertical angulation, and the teeth will appear long. This is how I look at it. If my PID is insufficient, meaning the tube head itself is downward and my PID is up, I'm going to think of it sun in the sky, right? As sun sets, my shadow gets really long because it's like it's showing it's going down. Whereas for shortening, which would be in excess of vertical angulation, meaning my tube head is higher than the PID itself, I'm going to get excessive vertical angulation, and this will have my teeth appear short and fat. Both are incorrect. We always want the same size tooth as what's in the mouth as on our film. Image receptor placement for bisecting. So the image receptor is placed close to crowns. Again, just a reminder of crowns of teeth, and extends at an angle to the palate or floor of the mouth. The image receptor should extend beyond the incisal and occlusal portions of the crown. Patient positioning. So when we have a patient sitting in the operatory chair, their mid-sagittal plane, which is their direct center of their nose, right? The center of their nose is the mid-sagittal plane. We want to make sure it's perpendicular to the floor. A good rule of thumb with that would be like their chin to be almost parallel to the floor, maybe slightly elevated. So patient's head should be upright for maxillary films and slightly back for those mandibular films, basically so we don't hit into the leg apron or the thyroid collar. Typically, we're using a number 2 film used in both anterior and posterior images, but we did talk about if we're using a number 1 film, we'll need more anterior images. We're rarely going to use a size 1 film for periapicals for an adult because the film itself is too small and we won't be able to see the entire area of the tooth plus the 2 to 3 millimeters below the root. So that's why a number 2 film is recommended for adults. Beam alignment. X-ray beam is directed to pass between the contacts of the teeth that are being x-rayed in horizontal but vertical must be at 90-degree angle to the imaginary bisecting line. So 90 degrees, you're right, that's a right angle, is your magic word. So the difference between paralleling and bisecting would be you're creating a right angle and paralleling to the long axis of the film, the long axis of the tooth and the film or sensor. For bisecting, that 90-degree or right angle is going to be created with the bisecting angle. So those are the two big differences between paralleling technique and your bisection technique. Now, this is new material. We did not cover bite wing technique, so this is brand new now. So the bite wing technique we use, so why do we take bite wings? So bite wings show the crowns and interproximal areas of both the maxillary and mandibular teeth, as well as crestal bone. What is crestal bone? It's that bone that looks like a wave that's in between the teeth, and we want to see if there's any loss of that crestal bone for periodontal reasons. They're used, bite wing x-rays are used to diagnose decay interproximally as well as bone level. The technique used is receptors placed in the mouth parallel to the crowns of both jaws. They stabilize when patient bites, meaning they're going to bite down on that tab. And the central ray is going to be directed through the contacts of the teeth using a 10 positive degrees of vertical angulation as a guide for you. Could that change? Yes, but ideally the central ray should be at a 10 positive. Image receptors, holders, and bite wing tabs. So Rin type receptors are the red holders that we use for bite wings. Typically those are the colors. Or we can use bite wing tabs, which are usually paper or a type of cardboard. Bite wings include one right molar shot, one premolar shot, or right premolar shot, a left molar, and a left premolar, so 2 on each side. For children that are a mixed dentition or primary teeth, we only need one bite wing on each side. Here's really important for any premolar shot, whether it's a periapical or if it's a bite wing. So premolar shot should include the distal of the canines, no matter what it is. And a molar shot should be centered over the second molar, whether it's, again, a bite wing or a periapical. Those are absolutely mandatory to tell that this picture is placed properly, positioned properly, and diagnostic. Premolar shot should have distal of the canine. Molar shot should be centered over the second molar. If you are taking the test for this, they are going to ask those questions because of placement and positioning. Now, let's talk about the occlusal technique. So the occlusal technique, which we briefly mentioned when we were talking film sizes. So for an adult, for us to take a occlusal film on an adult, we would need an adult size number 4. And for a child, we could use a number 2. What an occlusal picture is used or image is used, it's used to examine large areas of either the upper jaw or the lower jaw, not together, they're separate. So we're either going to take a picture of the upper jaw or the lower jaw. It's used to locate roots for extract that happen during extractions. Let's say, we think there's a root tip in there. After an extraction, they can use it for an occlusal. Are there supernumerary teeth, meaning extra teeth? Are there salivary stones and or fractures in the jaw? So for trauma. It could also another reason why we would use occlusal technique is to measure changes in size and shape of the jaw, as well as examine an area of the cleft palate. So let's again, what are occlusal technique used for, or occlusal films used for? Locate roots from extractions, supernumerary, salivary stones, fractures, measure changes in size and shape of jaw, or examine any areas of the cleft palate. Tips for occlusal technique. Now, we talked about the film. We know that there's one side of film or a sensor that is going to be the flatter side that doesn't have a label, that doesn't have an attachment. That's the side that you're going to face the arch that you're capturing. So if you're trying to get the maxillary, you're going to face that flat or that white side toward the maxillary jaw. The film is placed between the occlusal surfaces of the jaw, and when you have the patient closed down, it holds or stabilizes the film in place. This is what an occlusal radiograph technique looks like. One's the maxillary, one's the mandibular. Now, if we were talking about taking x-rays or radiographs on anybody with special medical needs, these are a couple of reminders for us. So if somebody is vision impaired, we're going to need to communicate clearly and explain procedure clearly so they have an idea of what we're doing and when, and we're not surprising them. We're just like barging into their mouth going, hey, we're taking these x-rays. Hearing impaired usually will have an interpreter, but if can read, lips talk slow. Mobility impaired, if they're unable to give assistance in holding a receptor, or we can use a caregiver. Sometimes children, they can't tolerate it, so we may need to get their parent in or caregiver to hold. We want to use the paralleling technique as much as possible to eliminate any risks of redo. If in a wheelchair, to take x-rays while they're in the wheelchair, if in a room is accessible. So we're going to treat it just like an operatory chair. We're just, if there's room, we may need to move our chair to be able for them to access it. And any developmental disabilities may be difficult to obtain good images due to their coordination, comprehension, and basically cannot tolerate. So we go by the provider recommendations. If we try, we are unsuccessful, then there's other ways to go about taking pictures, and we have to discuss that with the provider to be able to diagnose or figure out what area or what we need to do. So those were medical needs. Now we're going to talk about special dental needs. So special dental needs would be if a patient is edentulous, meaning without teeth. Well, one, why would we need x-rays for somebody without teeth? Few reasons. We're betting that they had teeth at one time. So they are used to detect residual root, if there's any objects embedded in the bone. And we also want to observe the quantity, how much, and the health of the bone that's there, that's left. Usually if somebody has had extractions of a full mouth extractions, the bone recedes or absorbs. So sometimes they may want x-rays to see how much bone is there, especially if they're going down the road of maybe getting implants, or if their denture doesn't fit, they want to see the quality and the health of the bone. Images usually will contain a panoramic x-ray and some periapicals only. We do not need bite wings because there's no crowns to be looked at. So it's just going to be a panoramic if that's the road we're going, and some periapicals only. No bite wings for edentulous. If you have a partially edentulous patient, a little helpful hint is you may need to use a cotton roll or a wad of gauze to keep the receptor in place because they don't have teeth to grasp the holder in order to hold it in its place. The pediatric patient, so a couple of things here, useful. Detecting conditions of teeth and bone. So why are we taking x-rays in a pediatric child? So we want to detect conditions of teeth and bone. Obviously, the sooner we see certain things in children, the better we can fix and hope maybe prevent things in the future. So again, detecting conditions of teeth and bone, changes in caries or if they had trauma. We're evaluating growth and development. The big key points with children is we want to explain to the child what we are doing. So we say things like, we're going to use a camera to take a picture of your teeth. We're going to call the lead apron a coat or a blanket, something relatable, something less scary. And as anything, exposure factors need to be lowered and use shorter time to avoid patient movement and blurred images. So a lot of things with children, tell, show, do method is what we do. We're taking them only as needed. And sometimes we have to get the caregiver to hold the sensor or film in place in order for us to run out and take this picture. Another special consequence here, or special circumstance is an endodontic patient. So let's just talk about endodont. Endodontic means we're doing a root canal, which means that we're drilling into the center of a tooth and removing the nerve and the pulp or any debris material inside. We do that using these very long files. Now, we also want to see how long the root is. We don't want to perforate the root. So we need to take multiple pictures or x-rays before, during, and after the endodontic procedure to ensure that what we're doing is accurate, because we can't see the result inside the root. So we rely on correct images. We're either going to use an endoray, that is that gray XCP, which has a hole kind of in the center where the file will peek out so they don't bite on it, or we can use bisect the angle. Again, all rules apply to whichever process that you're using. We always have to have the tooth needs to be centered on the image, and we want more of the apex, meaning 5 millimeters below the apex, not the average 2 or 3. I don't mind cutting off a little bit of the crown to get that extra 2 millimeters or 3 millimeters so you can see below the apex, because the endodontic procedure relies that we don't perforate the root and it's healthy and everything lines up to that apex, which is the tip of the root. Anatomically accurate as possible, vertical angulation is correct. Again, we want the correct size of the tooth in the mouth, from in the mouth to the picture that we're taking, to the image. Now, what happens if we have a gagging patient? Now, again, we're going to start, we know we're going to try to start with the anteriors. That's recommended, so we don't even start the gag. So exposure sequence becomes important. Anterior images are easier and should start the sequence, then your bite wing premolar, then your posterior premolars, and try to avoid the palate and do not slide along, place them. That means when we're placing the film or image receptor in their mouth or the roof of their mouth, we're not going to slide it, because that causes the gag. So we want to be very purposeful, be at the right placement, the right tooth, at the right positioning, and we want to be confident and go in, have them close, take your picture. Boom, boom. The quicker or the more efficient way we do that, the less time they have a thought to actually trigger that gag. If the gag is too extreme, then maybe a panoramic image may be the way to go. Again, that's going to be provider decision, but may be an option. Even though we can use a panoramic, a lot of times we really can't see decay clearly on a pan, so we may need to mix in some bite wings in order to see contacts where that decay would show. So there are some panoramic imaging or machines that can grab a bite wing so you can have an idea if we cannot get any bite wings whatsoever. Now let's talk about a couple of technique errors of what would happen here. And we talked about a couple of, like, the vertical angulation, the horizontal angulation, what that would look like. So diagnostic quality films are the goal, which we know. Why? We want one picture to get exactly what we want, so we don't have retakes, so we don't expose a patient unnecessarily. We must properly place at the right tooth, position the PID in the right area, or the film in the right area, and process, if we are processing, process each film accordingly without any errors that we saw in the last couple of chapters. We want to avoid retakes, and our key is to recognize the errors before they happen, or recognizing these errors is key. Ignore that figure 4129. Mounting radiographs. So here's important. If we did not have, so we know digital x-rays right now, they're going to show us what numbers we're going through or what areas we're doing. That's one. If we are not using digital that are mounting them for us, then we are going to have to use film and we have to manually mount them. But let me say this, you should know how to or know what teeth are where and where they should go in a mount in case you have to. You should always recognize, is this the right tooth in the right space? So let's say someone else took the the x-ray and you're like, man, that doesn't look like a number 5 or a number 12. That looks like it should be mounted somewhere else, or this isn't a maxillary, it's a mandibular. So there's certain landmarks, anatomic landmarks that you need to know. We discussed them last round and went through them. So obviously when we're mounting radiographs or looking at them, we want to verify anatomic landmarks. We want to separate the anterior from the bite wings from the posterior. We then want to separate the right and the left, which it looks like a natural smile line. So you can see right from left there that way. We want to identify the sinus. And so we want to say, oh, these are maxillary. So from the maxillary, separate them from the mandibular. Where we know mandibular has like that thicker bone density. We know maxillary has that nasal septum, some sinuses, and that angle of the arch, again, is that smile line. And if it has that natural smile, then we can see it more clearly. Again, we're going to select the correct mount. Is it 18 pictures, 19, 20? The methods of mounting are two kinds based from the ADA. Labial mounting, which is from the raised dot. Again, this is for film. It's the raised dot is faced up, meaning the patient's left side is on the viewer, your right. That's recommended. So labial mounting is recommended. The other is raised dot face down. This is patient's left is on viewer's left, as if you were looking out of the mouth. Not ideal. So when we look at x-rays, we're looking left to right. We're not looking through the mouth, like our eyes are coming through the mouth there. And it's always going to be dentist preference or provider preference. So again, these are just some of the reminders for the landmarks. Here we have that nasal fossa, your maxillary sinus, the coronoid process or condyle. If you did not know what that is, anytime you hear the word process, projection, that's going to be bone. So that's going to show that radiopaque, okay? That grayish area, grayish or white area. The ramus is the mandible, the angle, the body of the maxillary, the mandibular arch, the alveolar ridge. Again, this is just giving us some additional landmarks that we may not have covered. So this concludes this chapter. Again, on Thursday, we'll review a little bit. If you have any questions, please email me and let me know. And I want to wish you guys all a great evening. Thank you.